All right, guys, welcome back. This is Fei.
This is Nick.
And this is
Creogs over coffee. Okay, everybody. Well, thanks for coming back and listening. I have with me today two very special guests to talk on the topic of Rh blood testing in the administration of Rh immunoglobulin in early pregnancy, a topic that, if you've been keeping up with the literature, is hot right now. So introducing my two guests, first with me is Dr. Sarah Prager. Dr. Prager is a professor of OBGYN at the University of Washington in Seattle, where she is also the division chief of the Complex Family Planning Division and the director of the CFP Fellowship. Welcome, Dr. Prager.
Thank you.
Also with us today is Dr. Sarah Horvath, no stranger to the podcast, but just as a reminder, Dr. Horvath is an associate professor of OBGYN at Penn State Medical Center, where she also is the departmental vice chair of research there. Welcome, Dr. Horvath.
Thank you. Thanks so much for having us.
Okay, so I mentioned at the start that this is a hot topic right now, and I just have to start off with kind of thinking or predicating why exactly this is such a hot topic over the last few years. And I want to start with you, Dr. Horvath. Kind of give us the background, the context, the history of Rh immunoglobulin administration in pregnancy.
Yeah, absolutely. So before the advent of Rh immunoglobulin, there was always this problem for folks who are Rhd negative, that they could become sensitized when they were exposed to sufficient volumes of fetal red blood cells or other red blood cells that were carrying the Rh positive antigen. And so when you go back to the, pre-advent of Rh immunoglobulin, which for those of you who don't know is the generic name for RhoGAM. So I call it Rh immunoglobulin because I like to talk about it in a brand neutral way. So you'll be hearing that a lot. Before we had Rh immunoglobulin, about 15% of the population in the US was Rh negative, and they were at risk of becoming sensitized via blood transfusion or IV drug use, or most commonly, pregnancy. The biggest risk, because it's volume dependent, is at the time of delivery. And becoming sensitized in and of itself is not really a bad outcome. Like if you became sensitized and you never had another baby, or you never needed a blood transfusion, you'd never even know you were sensitized. The problem is that if you become sensitized in pregnancy, that pregnancy may not be affected, but your future pregnancies can have something called hemolytic disease of the fetus and newborn, which is when anemia occurs. And in rare cases, that anemia can be really bad. It can lead to high drops, and that high drops in even more rare cases can lead to death of the fetus or the neonate. This is clearly a terrible outcome and one that we want to avoid. Rh immunoglobulin was discovered in the 50s and 60s. It was FDA approved in 1968. And at that point, we started giving it at delivery. And then a little bit after that, we started giving it in the third trimester of pregnancy.
Thank you, Dr. Horvath. And to kick it to you, Dr. Prager, what are exactly the data surrounding efficacy at preventing hemolytic disease of the fetus and newborn?
Yeah, thanks, Dr. Burns. So as Dr. Horvath mentioned, if the Rh immunoglobulin is given postpartum, it reduces the risk from approximately 10%, the range is actually about 9 to 17%, down to about 1 to 2%. If then we add an additional dose in the third trimester, we typically are giving it around 28 weeks here in the United States, then we can reduce the risk from 1 to 2% down to about 0.1 to 0.2%. So that all looks really great. We've done a immense job of improving outcomes just with those two doses there. However, looking at giving additional doses earlier in pregnancy hasn't actually ever been shown to change that risk of 0.1 to 0.2%. So the earliest case report for sensitization that we have is approximately 15 weeks. But we still are recommending at prior to recently, giving RhoGAM or RH immunoglobulin throughout pregnancy, even in the first trimester, regardless of never having any data for it changing the outcome. This sometimes is called indication creep to earlier gestational ages without actually the sufficient evidence to support the practice. Sort of thinking, the outcome, yes, is terrible. So why don't we just give more earlier or whenever we can to try to impact that?
Got it. And I mean, that was a really nice explanation of the indication creep and some of the controversy that I'm sure we're going to get into here. But it is remarkable how effective this is in the second and third trimesters for bleeding or in prevention of HDFN. Dr. Horvath, even to make it a little bit more basic and kind of to go really, again, to the fundamentals of this topic, I want to ask you, what exactly is anti-D immunoglobulin? Really down to the basics for our listeners.
Yeah, absolutely. It's a human blood product. So it is an ultra filtrated product that comes from sensitized volunteers. This is most commonly men, but sometimes it will be, women who are done with their childbearing, who are either sensitized naturally or specifically sensitized to become donors. It's ultra filtrated again, so it's very safe right now. And I think it's really important to emphasize that people who need this medication absolutely should be getting it. We do think that it's an immense public health success to be giving it later in pregnancy and at delivery. And that's really important because the problem with it coming from donors is that it's susceptible to supply issues. I probably don't need to tell anyone who's listening, if you're listening right now in 2024, that there are shortages of this medication, right? And so there's a current shortage right now in 2024. And so because this is such an effective medication later in pregnancy and at delivery, we really need to make sure that we have enough of it to be used at those times. The other thing that I think we need to be aware of is the actual history. And I'm talking going back 50 years now, which is in the early days, we actually had outbreaks of hepatitis C in both Germany and Ireland that could be traced to RH immunoglobulin donors. This is really important because, again, very safe now, but if in the future we ever have a new pathogen that maybe we're not catching with the ultrafiltrate or something like that, hindsight has a tendency to be 20/20. And I'm really concerned that if that happens, people are going to look back and say, why were you using so much of this medication for indications that didn't have good evidence to support them, right? Because if that were to happen, people would be, irate on the other end. And you have injection site reactions and things like that, right? But I think the shortage issue is really the one that's the most important because while we're becoming really aware of it here in the United States right now, there's actually been global shortages so often. And it's really important that we recognize that and that we're good stewards of this finite resource.
Yeah, if I can just jump in there for a moment, talking about the shortages. They've been well documented in the United States over the past year or two. And as Dr. Horvath is saying, globally, there are parts of our globe where 80% of people aren't even getting the postpartum dose. So the fact that we have this limited resource that is being utilized at times when there is no proven evidence, and then 80% of people who are at risk for sensitization at a time when we know it could be beneficial or is beneficial are not getting it. That's really where we have to start thinking about resource utilization.
Oh, thank you for painting that picture to us. And I think that really colors a lot of the, again, controversy that we've been getting into about when we should be administering RH immunoglobulin. So I guess then that begs the question of what exactly does the data say? You all have kind of thrown out that we've been using it in these, data-free zones, but is there data? And if so, what does the data say about when we should actually be using RH immunoglobulin?
Yeah, that's a great question. So in the olden days, meaning prior to 2022, we really didn't have much data at all. And the Cochrane review from 2013 will tell you that. So anybody who's interested in the history can go back and look at that. There was one RCT done. It only had 57 patients. They didn't show any sensitization or any impacts on the 6 Rh positive pregnancies that happened later to their placebo group. But clearly, by today's standards, that's not really a powered study, anything that you could draw meaningful conclusions from. And so what we do have is these, the people starting to wade in on population level studies. Because we didn't have good evidence, the high resource countries that did adopt giving Rh immunoglobulin in the first trimester did it in ways that were variable. And so we were able to sort of compare those outcomes. My favorite study is one by Wiebe, where she looked at Canada and the Netherlands, and both of those countries are high resource countries. They both have pretty high rates of Rh negativity, meaning in that 15% range, and both have big government healthcare that is universal and connected to great data collection. So we have great data out of these two countries, and at the time, Canada was giving Rh immunoglobulin for all indications. They don't anymore, but at the time they were giving it for any bleeding at any gestational age. And the Netherlands was only giving it for induced abortion at less than 7 weeks, and only for miscarriage, at above 7 weeks, and then for miscarriage at above 10 weeks. So we had these really different strategies. And what you found that actually the clinically significant outcome was higher in Canada, where they were using more of this medication, than it was in the Netherlands. So your sensitization rate was, it was higher in the place that was using more of this medication, and that didn't make any sense, right? So this was one of the kind of early population studies that allowed us to start asking these questions. And then Hollenbach started using flow cytometry. She looked at 100 patients, and she found that actually the majority of patients already had some limited exposure to fetal red blood cells before their aspiration procedures. That's kind of interesting. That's kind of cool. And we were doing some flow cytometry work around the same time, and we were actually quantifying the pre and the post. And then we compared it to a very conservative threshold that we calculated based on those early studies. That had said 0.1 milliliters of exposure to Rh positive blood would be sufficient to cause sensitization. It turns out that the 0.1 milliliters, that study was based on, again, 15 people, but only 2 of the 15 people actually became sensitized with 2 doses of 0.1 milliliters. 2 more became sensitized with 4 and 5 doses of 0.1 milliliters, and the other 11 never became sensitized no matter how many doses they got. So that in and of itself is already a really conservative number, and we use that to find a threshold that we thought would be sufficiently low enough to really rule out any kind of harms when we did our work. We then did a powered study of 506 patients, and we found that of those 506, we looked pre and post abortion care. Some had medication abortion and some had a procedural abortion. So we had either, sort of consistent bleeding from the medications, or we had the inflammatory environment of having a procedure. So take your pick on which one of those you think would be more immunogenic. I've been in lots of smart rooms and people have come up with both conclusions. And so we included both. And we found that of the 506 patients, 1 did actually have fetal red blood cell exposure, antigen exposure above our thresholds after having a medication abortion. But she was one of 3 patients who'd already been just above that threshold pre-treatment. And so no one actually newly crossed the threshold after having an abortion, whether it was by medication or by procedure. And so we concluded after doing that powered study that you were not going to have sufficient bleeding up to 12 weeks to actually cause a new sensitization.
I just want to jump in there one more time. As Dr. Horvath is describing, her study was looking at patients who were receiving treatment for abortion. However, we have already translated these data to also be applicable to pregnancy loss. And again, I think we could be in smart rooms and argue both ways about whether or not this is more or less likely to lead to sensitization. And I think it makes perfectly good sense to me that if there's an 8-week pregnancy loss, then there's going to be the same, or in my mind, less opportunity for that fetal maternal hemorrhage than with an abortion.
Yeah, I would agree with that. We chose this population because we were able to recruit patients in a really efficient way. But we absolutely had in mind when we designed the study that this should be applicable to folks with miscarriage as well.
No, and I think that's phenomenal to have the foresight to be doing that and to recognize that potential concern with interpretation of the data. And again, also really exciting that you're here to give us insight into your own science and how that works. I mean, it's really exciting in its own kind of way to me. But before I get carried away, I want to make sure we stay on topic. We'll certainly post Dr. Horvath's work as well as some of the work that she referenced on our website, as well as in a future goals lesson. But Dr. Prager, I want to start with you and kind of understand the landscape after some of this work that Dr. Horvath has described in terms of the guidance that's coming from professional organizations, both here in the United States and across the world, because it still seems like there's a lot of potentially conflicting guidance depending on where you look.
Yeah, thanks, Dr. Burns. It's true. However, I feel like those data are starting to really coalesce around a pretty common guideline. Dr. Horvath already described that one of the studies that she was looking at was what they're doing in the Netherlands, where they were only testing and treating after 7 weeks for abortion, after 10 weeks for pregnancy loss. Those data really informed some guidelines coming out of the UK, including the ARCOG guidelines, which were to basically not test or treat until after 12 weeks, only if RH immunoglobulin is available. The National Abortion Federation started looking at this question also about 4 years ago or so, especially given that it was, or I should say, in the context of our needing to give RH immunoglobulin creating barriers to accessing abortion care at all. With a review of all of the available literature at the time, the National Abortion Federation came up with a guideline to test and treat after 12 weeks. Initially, it was after 8 weeks for procedures, 10 weeks with meds, and then after actually Dr. Horvath's data was published, switching to 12 weeks. And then in 2022, the WHO did a publication, updated their guidelines, assessing all of the new data, including Dr. Horvath's data. And the World Health Organization recommendation globally is also to only test and treat after 12 weeks. That was published in March of 2022. And then the Society of Family Planning guideline that Dr. Horvath and I were both a part of in terms of crafting, that was published in the summer of 2022 and recommends testing and treating starting at 12 weeks, 0 days. So that was kind of the landscape with everything coalescing. And at that point, ACOG was kind of the holdout. But there were also other organizations that kind of hadn't weighed in on that yet. And I'm going to pass that ball to Dr. Horvath to finish telling the story.
Yeah, so that's kind of where we sat. There were a couple of new guidelines coming out of WHO, SFP being kind of the big ones. And then the shortage happened and people started to ask a little bit more loudly, what should we do? Now we're getting sort of conflicting guidelines. Some people have updated, other people haven't. I think mostly the ACOG and SMFM holdouts were really difficult for people to to sort of navigate. So SMFM did come out with their guidelines then right around the time of the shortage starting. And they said basically that you should continue to test and treat as long as it doesn't cause a lot of challenges for patients, right? And so they sort of dug in and said we should actually continue to do this because it makes sense, right? Our MFM colleagues are the folks that sort of see the bad outcomes when they happen. And so they said, we reviewed the same data and we think that it's of low quality. And so we should keep doing what we've been doing. Interestingly, the French guidelines came out on the same day, and they also said, we've reviewed all the data. We think if it's of low quality, you should stop giving RH immunoglobulin below 12 weeks. And so it was really funny to look at these two guidelines on the same day that were kind of like said the same thing and then came to exact opposite conclusions. And so that's kind of where we sat. And then Canada came out and they updated their guidelines a couple of months later. So Winrow is one of the brands that had been invented in Canada. It was kind of a Canadian US thing when we first got RH immunoglobulin. So they had been very gung-ho on giving it to everybody. And they actually came out over the summer then and said, definitely not before 8 weeks. And between 8 and 12, you really shouldn't. But if the patient wants it, you can. So they kind of split the difference. And then hot off the presses, ACOG is going to officially publish in December, but you can get it online now. ACOG decided to update their guidance in accordance with WHO and SFP and say you should not be testing or treating below 12 weeks. So I think at this point again, we are really coalescing around that 12-week marker. And I really want to emphasize again, I think that the subtlety of this, and this is addressed in the SMFM guideline too, is that in times of shortage, when you're not sure what you should do, you really have to use this finite resource at the times when we have the best data. And that's delivery and later in pregnancy. And so if you're given the chance to do the right thing kind of globally and for the population, it probably means not giving it really early, or certainly, at least in most circumstances, not giving it in those first 12 weeks so that you can conserve it for those times when we know we have good evidence.
Just to hop in there for a second again, I think it's also important to point out that none of these guidelines and none of these studies have any direct data about what do you do with an ectopic pregnancy, what do you do with a molar pregnancy, and how these guidelines have kind of addressed that is not the same. So in those two situations, we are in a data-free zone, and I think we can, make inferences, and they could actually go in either direction. So we don't really know what to do at this point with ectopic pregnancy or molar pregnancy.
Oh, thank you both again for that really excellent and context provision with your overview, because it really does kind of paint the story of how folks have come to be and how thinking has evolved with this, and again, being shaped by the context of what we're experiencing, particularly in the RH immunoglobulin shortage, and trying to make the right decisions for all of your patients, but being mindful of the limited resource that we have. I want to come back to something with you, Dr. Prager, that was mentioned earlier in the context of these Canadian guidelines, where a patient may request RH immunoglobulin between 8 and 12 weeks or before 12 weeks. And I kind of think in this sense of, to put it in my own context a little bit more, elective induction and some things surrounding that, right? Of like, the patient says, well, I was induced at 37 weeks in my past pregnancy and it was no big deal. And now there's this big red line that says there's nothing elective before 39 weeks. And trying to think about an analogous patient who says, well, I got RhoGAM before. I know that I need it when I have bleeding. Why are you not giving it to me now? What do you counsel our listeners who are maybe encountering this scenario to do if encountering a patient like that?
Yeah, great question. And like in all of those situations, I think utilizing shared decision making is the way to go. So it's not uncommon for patients, just like providers, to have a hard time foregoing therapies that they're used to receiving or used to providing, even in light of good new data. So if I have a patient sitting in front of me who says, I got RhoGAM for all 6 of my prior pregnancies, and I'm having bleeding at 11 weeks and I want RhoGAM again, I'm going to say, are you aware of these data? And if she says, I am, and I still want my RhoGAM, I'm going to say, great, let me give it to you. Now, I also am in a resource-rich providing environment where I can do that. And so we can talk about the ethics of that another time. But I do think that, making sure that patients are well informed about risks and benefits of anything that we're giving to them, and then utilizing shared decision making so that they can feel comfortable with their care is always appropriate.
And that's consistent with all the American guidelines too. Even the ones that conflict with each other, they all sort of leave room for this idea of shared decision making in both directions.
Yeah, absolutely. It's one of my favorite part about those guidelines, frankly. Another one of my favorite things to ask residents about in particular is about the different doses of Rh immunoglobulin, because many kind of, if they're new to this subject, just think, well, you just give the RhoGAM, right? And there's no concept of a dose. So let's describe that for folks. Sort of what doses of Rh immunoglobulin are really necessary at different gestational durations.
That's a wonderful question, and I think also sort of an ethical dilemma, because when those residents are thinking, "Oh, just give the dose," they're talking about a 300 microgram dose, and the 300 microgram dose is what is standard at delivery and in the 3rd trimester. However, because we talked about way at the beginning of this podcast that this is a volume-dependent process, actually earlier in pregnancy, you should be giving smaller doses. So in the old guidelines, when ACOG was recommending Rh immunoglobulin before 12 weeks, they were recommending 50 micrograms. I'm going to struggle with saying that word. 50 micrograms. And that is still true if you do have those molar pregnancies, those ectopic pregnancies, some reason why you think you do need to be giving it in early pregnancy, 50 is a sufficient dose. We have one study that shows that between 13 and 18 weeks, you can give 100, and that is probably sufficient. In fact, in Europe, rather than giving one 300 microgram dose at 28 weeks, they give 100 at 28 and 34 weeks. So there is room for giving these smaller doses. But here in the US, we really say by 18 weeks, you should be giving 300. Okay. So if you have somebody who is coming in with abruption, late 2nd trimester into the 3rd trimester, things like that, and you're concerned, you should really be giving that 300 microgram dose. And that's good for up to 12 weeks. So it's not the kind of thing that you have to be redosing all the time. I know that most hospital systems do only carry that 300 microgram dose. And in fact, I was speaking with all the folks at the transfusion medicine conference just recently, and they were like, oh yeah, no, hospitals, no, we don't actually carry anything smaller. And that's why we think of it as being one single dose. But actually, if you go out to clinics that do high volume miscarriage care or high volume abortion care, a lot of them do carry that 50 microgram dose, and they're much better stewards of the medication because they're giving 1/6 the amount when that's what's sufficient.
Oh, thank you for that. Again, one of my favorite little factoids, because yes, it's not just the RhoGAM. There's some differences there. I want to kind of end our podcast talking to you both and sort of your reflections on this and looking towards the future. And really sort of in your estimation, or if you could leave our listeners with some things and inspiration of what to think about for their future projects or careers. What do you all think still needs to be done in this space to preserve, again, this finite resource?
A great question. I'll start and I'll let Sarah play sweeper here. I mean, we at the top, Dr. Horvath mentioned that what we're really worried about is hemolytic disease of the fetus and newborn. We don't really care about sensitization. And so if we could design and execute a study where we can actually look at subsequent pregnancies in people who have received or not received RH immunoglobulin at different gestational durations for both abortion, miscarriage, molar pregnancy, ectopic pregnancy, and ongoing pregnancies, and then looking at outcomes in terms of hemolytic disease of the newborn, that would be the holy grail. I think that is unrealistic. We're not going to be able to get funded to do that particular study, but we can do parts of that study in different ways and at different times. And I know Dr. Horvath is already working on some of that, so I'll let her describe her current work. But I would say, I would love to see a study similar to the one that Dr. Horvath has already studied specifically for miscarriage, just so we can kind of put a pin on that and prove that beyond shadow of a doubt. And to also look at ongoing pregnancies in the first 12 weeks that are experiencing bleeding.
Yeah, I agree. I think that those direct studies are the next step in the science. And I'm also incredibly interested in patient risk tolerance and what they are willing and desiring in this space. Because, again, the one consistent thing in all of the recommendations is that you can engage with patient shared decision making around this topic. It's a complex topic. It's a complex topic even for residents. And so to have a truly informed discussion with an individual patient in a time of potential stress is really difficult. And so I think both the science and the patient-centered decision making and tolerance for risk are really important things that we need to be taking into consideration as we move forward. My ultimate goal is to have a universal evidence-based recommendation for using Rh immunoglobulin in early pregnancy. I would love to get to a point where everybody says the same thing. We have one thing that we do, and it's based on really good science.
Well, phenomenal. Thank you both for your time. This has been a really excellent conversation. And again, I will say on behalf of our listeners, we really appreciate you demystifying some of this that I think at our outset seemed kind of controversial, but now I feel like it's a lot more clear. So again, thank you.
Thank you.
Thank you for having us.
All right, once again, this is Nick.
This is Fei.
And this has been Creogs Over Coffee.
So guys, if you enjoy the show, go ahead and go on to Apple Podcasts, Google Podcasts, Spotify, your favorite podcatcher. Give us a 5-star rating and review.
You can find show notes for this episode on creogsovercoffee.com, but remember, check out our newest project, Goals, at www.obgyngoals.org to supplement your learning even further with multiple choice questions, more audiovisual resources beyond the podcast, and oral board style cases. We think you're going to love it.
You can also find us on the social media on Facebook and Instagram at Creogs Over Coffee, on X at Creogs Over Coff 1. Make sure to like and follow.
And finally, if you have a question for us, a correction to this episode or any of our prior episodes, or just want to say hello or suggest a new lesson, email us creogsovercoffee@gmail.com.